Hello.
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 We're just waiting a few minutes to make sure we've got everyone, then I'll introduce Dr Colette Ferguson.
Okay.
Just that I noticed there's a few sites online but no one there yet.
All right.
Here we go. Can everybody see everybody else that's on? No. No, you can only see into.
I think they'll just see our presentation. So what we might do is I might actually just do a little introduction. So we'd just like to welcome Dr Colette Ferguson, who's Director of Nursing, Midwifery and Allied Health Professions in NHS Education for Scotland. Clin Ed South Australia actually sponsored a visit for Dr Colette Ferguson to come across, and we've been very lucky to actually be able to invite her to Tasmania as part of that visit. And it was very generous of Clin Ed to offer Dr Ferguson's expertise to us. Dr Colette has a long-standing career in nursing practice and education before taking up a national post with NHS in Education for Scotland in 2003. She's a graduate of the University of Edinburgh, where she was awarded an MSc in Nursing and Education in 1992 and a PhD in 2000. Dr Ferguson's specific area of interest and expertise is in practice-based learning, and she's led and implemented a national network of practice education facilitation and education support system of nurses and midwives across Scotland. More recently, Dr Ferguson's leadership is focused on strengthening access to education for nursing midwives, allied health professionals and their support workers across a range of settings, including the health and social care workforce. So, welcome Dr Colette Ferguson.
Thank you very much.
And just maybe it might be good for us all if we could just go around and identify who is actually online, if that's possible. I think starting with Hobart.
Robin Rankin, I'm the occupational psychologist for the Department of Health.
Alison Evans, Safety and Quality Consultant for the Royal Hobart Hospital and THO South.
Okay, King Island.
No, I don't think.
I've got a King Island.
Yeah. I don't think.
Rosebery Community Health Centre on the West Coast, Loris Cole, a clinical nurse.
And Helene Blackbriar, clinical nurse, registered midwife. Hi.
Hi. Anyone from
Bernie.
Oh, Bernie.
Bernie Community Nursing.
Judy Harris from Living Well, Dying Well Project, East and West.
Georgetown. No, it doesn't seem to be anyone. Devonport.
Mr. Rob.
Okay, I can't see who's at the bottom.
No, I can't see the bottom ones.
So anyone else that we've missed? Just that we can't see all the names of where you're sitting on our screen.
Launceston, Allambie.
Yeah.
Lee Wallace, ADON of Rehab and Subacute Services.
Wilhelmine Bigney, Infection Control.
Joy Farrell at Georgetown Hospital.
Okay. So do we have everyone? Just to give you a bit of explanation, we're sort of sitting here looking at 12 screens and we can't actually see all the different titles, but as you speak they will come up and we'll be able to see them. Okay, I'll hand over to you, Claire.
Okay, thank you very much. Hi there, thank you very much everybody for A, for coming into the session today, and B, for inviting me across here to Tasmania, which has been a really good experience so far. I'm here probably just to share with you some of my work that I've been doing in Scotland around about practice-based learning, and to share some thinking, maybe to stimulate a bit of discussion around your own situation, your own context, and look particularly at support systems for practice-based learning, and then talk a wee bit about Flying Start, our transition programme for new graduates. I'll try to speak a bit more slowly. I tend to speak very quickly, so do please interrupt me if you feel you need to. What I will do is I'll work through a PowerPoint presentation just to give you some background, talk a wee bit about the Scottish context, some of the similarities, some of the differences, talk a wee bit about nursing, education in particular. My role covers nursing, midwifery and allied health professions, and as an organisation we cover all of the professional groups within healthcare, but I will focus mainly on nursing and try to extend that a bit further. As I say, more than happy to answer any questions, but hopefully if we do a bit of the presentation and then we'll open it up for discussion. Do you want to say who's here in the room here, just so that you know?
So who we have here is
Sharon Cody, Health Workforce Australia.
Laurel Grubb, Education and Training Unit.
And Kelly Taylor, Education and Training Unit.
Right. So, are you okay if I just carry on then? Does that sound okay?
Yeah.
We'll take silence if yes. As I say, can you all see the screen? First of all, we've got a PowerPoint presentation now going on.
Yes.
Yes, thank you.
Yes, thank you.
Thank you. That's great. And you have to bear with me. This is quite challenging for me. It's the first time I've probably done a session to 11 sites coming in, so which is really super. So as I said, what I'll do is talk a wee bit about the background, our health system, a bit about nursing, midwifery education, practice education support, and what that support looks like, and the transition. And then we'll open it up for a more general discussion. I wouldn't worry too much about the PowerPoint slides I've left with Lauren, and I mean if you can get access to them later if you want to. And some of the things you might want a bit more information on, and we can make sure we follow that through.
So we'll forward you a copy of all the PowerPoint presentations tomorrow.
I'm starting off with a slide of Scotland, and it's really just to give you some indication of the geography in which I come from. Scotland is one of the 4 countries of the UK, and I'm sure most people know that. Some of you may have well been there, or certainly been to the UK. But it was just to highlight, we are one of the 4 countries. And you can see from this map area, I've put it up deliberately to demonstrate some of the remoteness, the mountain areas that we have, the island areas we have. And while on a very much smaller scale than Australia, we probably have some of the similar challenges to you in terms of how do we really reach our practitioners and our patients in these remote and rural areas? How do we make sure we've got the right healthcare system? And how do we make sure that our practitioners are as up to date as they need to be? So some of the challenges for education and training, I think we can probably share, albeit in a different scale. You can see from our population is about 5.5 million. It says 5.2 here, but our population has increased and it's continuing to increase. But the biggest bulk of our population is in some of our kind of key city areas. I've put on the slide a bit about our life expectancy, and it's again just to demonstrate. I think that's possibly similar to Australia, but we've got quite a bit of inequality in terms of our life expectancy and our healthcare. And there can be a difference in life expectancy of 10 years from some of our affluent areas to some of our poorer areas in Scotland. And I think particularly if I look at some of the big cities like Glasgow, from one end of the city to the other, you can have a change of 10 years in life expectancy because of the inequalities in health and care. As I said, we're one of the 4 countries of the UK, but we have a devolved administration, a devolved parliament, and that devolved parliament is responsible for health and education, among other things, but health and education is what we want to talk about today. So the responsibilities, accountabilities, the funding is within our own Scottish Government for health and for education, but regulation, as an example, is a UK-wide responsibility. So while we may well make decisions about health and about education, we are challenged because of the UK nature of regulation. So we cannot work in isolation of the other 3 countries in the UK. And to some extent that's good because it allows for people to move across the 4 countries. But it does give us some challenges as well if we want to move forward with some very specific developments for our workforce population. Our health boards, our country is divided into 14 what we call territorial health boards. And if you think about something similar even to your regions, where those health boards would be responsible for the delivery of all healthcare services within that region, both at primary and acute care. They're independent in terms of their funding, their responsibility, their accountability, and their budgets. As well as that, we have 8 what we call national boards or national special boards, and education is one of those boards. So the territorial boards are responsible for the healthcare provision. And if I take the NHS Education for Scotland, which is the board I work for, is national, and we would support all of those boards with education training for the workforce. Some of the workforce development education will be carried out locally. Some of the strategies will be local, but what we're trying to do as an organisation is look at more what can we do that's once for Scotland that reduces duplication of effort, it is more efficient, and it can increase benchmarking and quality. So we've got 14 territorial health boards. We're probably challenged with some of the kind of global challenges that everybody's experiencing just now in terms of the demographics, our changing population, our older people's population, the growth in that area, and the multiple morbidities. So again, really changing the demographics than what we had even just a few years ago. We've got very strong policy leadership from our government, and there's 2 key areas I think that we're focusing on just now. One is about the shift from acute service-orientated care to primary care, and we're looking at the integration of health and social care. We've been looking at that for a number of years, but we've got a policy shift in that, and there's a bill going through Parliament just now to really try to ensure integration of health and social care, which would include integrated budgets, so that we can look at administering care and delivering care closer to where people live, and try to reduce the dependence upon acute hospital care. So that's one of our big policy areas, and that's got huge implications not only for how we configure our services, but it's also got huge implications for education for all of our professional groups. So that's something that we're really working very hard towards just now. The second area of our key policy is around improving the quality of care, and we have a quality strategy for the NHS in Scotland that has got three key areas of ambition. One is around safe, one is around effective, and one is about person-centred care, to making sure that people do actually have the most appropriate access to the best quality healthcare as close to home as they possibly can, and that it is tailored and focused on individual requirements rather than on structural organisations. So that's really big for us just now as well. So 2 key areas of policy. One is shifting the integration of health to health and social care, and the other is about raising the quality of the healthcare provision. Talking about the special health boards then, I mentioned about our own NHS Education for Scotland. We were created in 2002, and this is some of the conversations we've been having about what does it mean to have a national body supporting education and training. Prior to 2002, we had individual organisations looking after postgraduate medical and dental education, nursing and midwifery education, and pharmacy post-qualifying education. And these 3 organisations came together under the one umbrella of NHS Education for Scotland in 2002. And since then, the other professional groups have all come on stream: the allied health professions, psychology, optometry, bioscience, paramedics. So everybody is now under the one umbrella. But that also includes our healthcare support worker staff, our administration and clerical staff. So really we have taken on the responsibility for the education for the whole of the health service. Now that doesn't mean the responsibility for delivering it, but the responsibility for overseeing and making sure that the right kind of education training is in place to really support our workforce. You can see here that we're responsible for postgraduate training of junior doctors and dentists, clinical psychologists, pharmacists, nursing. So that's really more or less just what I've said. I'm going to now focus in a wee bit on nursing in particular, and thinking then I'll move on to looking at nursing and allied health professions. And what I've come to is the key areas that we're looking at as part of our strategy. One is about looking at how we support nurses, midwives and allied health professions across the workforce. And the second is that how do we really make sure we've got the right kind of practice education infrastructure. So I thought I would talk a wee bit about the practice education infrastructure first of all. And probably before about 2003, when undergraduate nursing education moved into the higher education sector, there was a perceived gap in relation to the quality of support that people had in practice in relation to clinical teaching and direct support. The decision was made that our staff nurses, our registered nurses and midwives would be the key people who were supporting students in practice, and they would have a role in both their supervision and their assessment. I'm going to use the term mentor, and I use that only because that's the term that our council, the NMC, use the term mentor to describe those who are supporting students in practice. Now, we could have a debate about whether that's the right term or whether we should be using preceptorship, clinical supervision, and I'm not going to go there, but it's really just to kind of put that in that context. When I'm going to be talking about mentorship, I really am talking about that broader role of supervision of students in practice as well as their assessment. But what became very clear is that the mentors were expected to supervise students, they're expected to deliver care, they were expected to make some very complex decisions about students' ability to progress, and they weren't really supported within that role. And there was quite a lot of complaints about students being fit to practice at the point of registration, about the loss of what was the clinical teacher role, and how that was a really important role in making sure students were fit to practice. In 2003, our government minister at that point in time had been listening to practitioners sort of saying, well, we need some sort of support role here, and what do we need to do? What additional support do we need to put in for students? And at that point in time, we talked about what was required. We had issues about placements, about the number of placements, the quality of placements. So through looking at the listening to people and also looking at the literature, understanding what the needs were, we decided to implement what we called the Practice Education Facilitator role as part of a whole systems approach to try to improve the quality of our learning environment. Now, this is over and above what clinical education roles are already in place in very specific areas. So this was a national initiative where there was funding for 100 whole-time equivalent posts across Scotland that would be paid for. 2/3 of that would be paid by government, and the other third would be paid by the board that was employing these people along with their university partner. As I say, it was part of a whole systems approach. We wanted these people to be employed in practice. We wanted to be embedded in the boards, because one of the issues with clinical teaching model that we had before was they were employed by the universities and they were seen to be almost like a guest within that clinical area, you know, coming in and going out. So we wanted to build a model that was there within practice and would support practice. We wanted to focus on supporting mentors because we felt that would give us a more longer term sustainable infrastructure and investment, rather than focusing on, in particularly on individual students, which would be a more short-term look at support. And we felt by supporting mentors, we could give students a far better experience. Initially, the role focused very much on undergraduate, but it wasn't meant to be only about undergraduate students. It really is about supporting the learning environment. And the key issue about this particular role, 100 whole-time equivalent posts is not a lot across the country, as for the size of the population and the diversity of Scotland. But actually, once we actually employed people within the boards, we're probably talking about 120 or so headcount when we come to the posts. But the important thing was that we were making this a national network. So we had a national induction programme and development programme, core job description. So there was a core element to the post, and then some flexibility for the individual board areas. But the key thing was that we would be looking at national consistency in terms of that support for mentors, and also that would support the mentor development. The key tool that the Practice Education Facilitator had was what we call the quality standards for practice placement. And this was a set of standards that we developed in 2002, 2003, based on the best available evidence that we had at that point in time, that looked at what were the requirements of a clinical area to be a good learning environment, what was the role of the supervisor or the mentor, what was the role of the managers within that area or the organisation, and again, what's the role of the student in terms of like meeting their own learning needs within that area. So these standards were published, and then we've developed an audit tool. And the practice education facilitators use these standards as their way of monitoring and maintaining that learning environment and sharing that with our university partners. So we work very much in collaboration with the universities around us. The third bullet point that's on that slide is about a national approach to mentorship. So we have the PEF role, we have the quality standards, but what we were realising was that every university in Scotland had their own preparation for mentors, which meant we have 11 university providers for pre-registration nursing midwifery, and potentially every one of those universities would have their own supervisor or mentor preparation. And that supervision, what would happen is if somebody was working in Aberdeen and they did their mentor preparation and they moved to Glasgow, they needed to repeat it because it was a different and it wasn't acceptable, there wasn't that transferability. So one of the key things that we did was we brought together our university partners along with our key clinical education people from our boards to look at what would be a core national approach to mentorship. And I'll come back to that because that was really important, that we had a consistency in terms of that approach so that it was recognisable and it was recognisable and transferable across a range of organisations. This is a bit of a busy slide, but I really wanted to just give you a feel for what the core role and function of the Practice Education Facilitator was, because it was quite unique. Most of the other models of practice education in the UK were really about clinical teaching, clinical supervision, and focusing very much on the individual learner's needs. We wanted to provide support for mentors to ensure effective supervision, assessment, and informed decision making. We wanted to assist senior nurses enhance the quality of their learning environment through ensuring education and development opportunities and the needs of students and registered practitioners are addressed and supported effectively. We wanted to contribute towards cohesive partnership working with the universities, our boards and the colleges. The fourth bullet is probably quite key. We wanted to maximise the number of learners that were supported within clinical practice areas, because we were always struggling to get sufficient placements and getting the right kind of placements. And because of our service changes, quite often there was service reconfiguration, and where we might have been able to send a student one day, the next week it might have been changed, the service needs might have been changing. So it was really important for us to get a real grip on what placements and what learning experiences were there. We wanted to ensure the development of new and experienced mentors, and we wanted to contribute to the nursing midwifery policy agenda through facilitating quality practice learning opportunities which demonstrate improvements in patient care and experience. So we want to keep the focus primarily on the delivery of quality care and what that meant. And our mentors are our frontline nurses, and their quality of care is what they're role modelling. So for us it was really important to support them as much as we could. And we wanted also to provide support for staff participating in continuous professional development activities. That's quite a tall order for what was a relatively new role. And as you can imagine, if we were looking at having a core job description, everybody wanted these people, all few of them that they are, to be doing everything. But we kept the focus very much in the first year on looking at really building up the learning environment and supporting those mentors to meet the Nursing Midwifery Council standards for learning and assessment and practice. And over the funding was for 3 years in the first instance, and even by year 2 people started to get a bit unsettled, thinking what's going to happen here, am I going to have a job, is this going to go? But our board nurse directors and our universities from the very beginning were saying they didn't really know how they managed to do without these posts. They were actually making such a difference. So by the middle of year 2, in negotiation with government, we managed to secure ongoing funding. So the posts then became part of our embedded infrastructure, and we continue to support them now. And the funding now comes through ourselves as NHS Education for Scotland. So we pay 2/3 of the salary of these post holders, and the individual boards and their partners pay the other third. Now that's been, I think, key to how we've managed to take things forward, because it allows us to really influence at a national level, to make sure that the core purpose of supporting mentors really continues to happen. And each year what we do is we meet with the nurse directors and the leads in the boards, as well as the education leads, to set their objectives for the year to make sure that they're actually addressing what they need to be addressing. And we have annual updates, we have annual reports looking at the outputs from the post holders. It's important to say this was in addition to any support that we had in individual hospital areas or board areas beforehand. So having the network is actually a really good conduit for even from policy to practice, because we keep a database and we can actually work with our Practice Education Facilitator network. We have employed 3 coordinators, one of each of our 3 workforce regions, who then look at annual updates for our PEFs and our mentors, and we also involve them in learning and study days. I'm putting up now just some of the responses that we've had from the evaluation of these posts, thinking back to what our key purpose was. And what we're seeing from the evaluation is that the PEFs absolutely contribute to the expansion and scope of practice learning opportunities. We have got many more contemporary care placements and learning experiences for our students. We've been supporting different models of mentorship and team mentorship. We've been looking at hub and spoke models where the student would have a primary learning hub with a mentor, but they would actually have what we call different spokes where they would go out to different areas for a very managed experience. And we've done some research around that, and that's recently been published, which has been really fruitful. We've developed new placement areas, and we've also established robust and up-to-date mentor databases in every NHS board. So within each of our boards we know how many people have been through a mentorship programme. We know who's due to have an annual update and who's due to have what the NMC require as a triennial or a 3-year review in relation to their competence. But what we're seeing at the bottom there is the practice learning experience needs to evolve further to reflect the policy direction of services, more focusing in on our primary care areas and less on our acute areas. I think we've actually got a very strong, robust structure within our acute areas. We've probably got less so within our community areas, and that's one of the areas we want to address. The second bit, other than building capacity, was about supporting mentor decision making. And the PEFs not only are there to support mentors, but stopping students failing. So helping mentors to make assessment decisions that are valid and reliable and indicate the learners are fit to practice. A recognition from their service and education colleagues of their vital role in supporting mentors to manage students who are causing concern and helping to ensure a safe and effective workforce for the future. This part I think has been critical because, as you probably all know, and it's not just about nursing students, it's about any students, when students are good, they can actually be a really, really fruitful part of our team. They can really energise, they can be absolutely superb. But if you've got a student who has got some challenges or some difficulties, that can be really, really time consuming. And what we found in the past was if students were only in given areas for short periods of 4-week placements, it was very difficult really to get under the skin of that, especially if they maybe had some issues around about their attitude or their interpersonal skills. Quite often what would happen would be in assessment the mentor might decide that the student's not quite there, but they're getting there, and would give them the benefit of the doubt. So they move on to the next placement and the next placement, and people would continue to give the benefit of the doubt. And what would happen is you could get to the end of a 3-year programme, and all of a sudden somebody's about to register, and people are saying, well, I don't think they're fit for the register. So actually supporting mentors in some of the decision making has been very, very important, because it means quite early on if a mentor would have a discussion with the practice education facilitator if they've got any concerns at all about their student, and together they would work to look at, well, what would be our action plan around that? How do we help this person to meet the specific competency area? Or if it's an interpersonal or an attitudinal issue, it would be addressed much more quickly. There was some evidence to support that argument. A number of years ago, Cathy Duffy did a study, and it was published as Failing to Fail. And it explains the reasons why we actually managed to get there. You know, the fact that we can actually allow students to go through the people who are very significantly not performing. It's quite easy to pick them up, but those that are kind of subtly challenging around some of that can be more difficult. So what we've found is actually introducing the PEF role, the practice education facilitator, to support the mentor. Those decisions are actually much more transparent, and they're much more open, and the students are actually dealt with much earlier on. So I think that's been very, very significant for us. Before I go on to mentor preparation, the other thing I would want to say is in terms of the practice education facilitator role. While we started it within nursing, we now have practice education facilitators in the allied health professions. The role is slightly different, but because the number of professional groups is different and some of their issues are different. And one of the key differences is about in the UK, and certainly in Scotland, nursing, midwifery, medicine and dentistry are what we call controlled subjects, that the government decides on the number of people that we're bringing into our programmes, and therefore we can absolutely decide, we can look at and identify how many placements we're needing for students. In our allied health professions and some of the other professional groups, they're not controlled by government, so the universities can take in as many as they want, but actually the big challenge becomes the placements and how do we get the right kind of placements. So some of the challenges for our allied health professions have been how do we negotiate with the universities around A, the students that they have, and B, getting them the right kind of placements and the right number of placements, and sometimes those two things don't marry. So we've had to do some work around that. The mentor preparation, just going back to that for a second or two, the Nursing Midwifery Council require mentors to have a 10-day preparation. 5 days it needs to be face-to-face, and the other 5 days is more reflective practice, working with students. Now that's a huge resource issue for the NHS across the UK, and it's being challenged by the board directors across the UK countries, so NMC are being challenged on that. But currently that is the standard that we need to achieve. I would suggest in Scotland we could never have achieved that if we didn't have our practice education infrastructure, if we didn't have those support roles. But the PEFs have been absolutely fantastic in making sure that they contribute to the mentor preparation. They would sit down with them and they would carry out reflective sessions with them, and they would do the annual updates. So we are finding we're achieving that, but that's been quite difficult. One of the bigger challenges was also about the number of different mentor preparation programmes. And I've mentioned it earlier on, but really just to demonstrate here, what we came up with was a national approach to mentor preparation, and it was a core curricular framework. So we've not prescribed a curriculum, but what we have done is we've actually identified what the core elements of that curriculum need to be, and then what are the flexible elements. And different universities and different boards will deliver that in different ways, but it does mean that we've now got some transferability, and there's not need to be that degree of repetition for our mentorship if they've done that across the country. The 3 themes within that document are learning, professional relationships and accountability, and assessment, and there's a learning unit assigned to each of those that people do within the face-to-face contact, but they then follow through within their practice. When we were working on this document, we realised that the principles of learning within the mentor preparation, albeit this was driven by nursing midwifery, the principles are the same for all of our professional groups. And we worked then with our allied health profession colleagues, our pharmacists, our psychologists, and we developed a generic version of this, which was the generic guiding principles for practice learning, which can be used across professional groups. I'm going to stop there just very briefly in case there's any burning questions. I realise I'm just talking for a minute or two, and then I'm going to go on to look at our post-registration experience. I've covered quite a lot there and talked quite a lot, but I just wonder if there's any questions anybody wanted to ask. It's always a bit more difficult when we're on video conference. Yep.
Hello, it's Lee Wallace in Launceston. I just wanted to know, so you actually have the facilitator role as well as clinical educators in your clinical areas?
Yeah, the clinical educator roles are not consistent across our clinical areas. They would be, some of our specialist areas will have clinical educators, but not all of them. So I think our system is quite different than yours. Your clinical educators are employed by the board or by the university?
No, they're actually employed by the hospitals, by the actual facilities.
Yeah. So some of our hospitals will have clinical educators. We're more likely to find them in specialist areas, but there's not a consistency across all of our hospital areas. Every registered practitioner, whether they're a nurse, midwife, allied health professional, medic or dentist, is expecting to support and supervise students, but there are different systems within each of the professional groups. We would have some trainers in medicine and dentistry. We have clinical educators in some of our areas, practice educators. They've got different models across our health boards, so we don't have a consistent approach within our clinical practice areas. So these posts would be over and above that.
Okay, thank you.
It's Julie Kingston at Beaconsfield. How does that work for your primary health areas with the these facilitators? How do they actually are they responsible for a number of small primary health areas, or how does that work?
Yeah. What they would be doing when the number that we had, and as I say, the number we have 100 whole-time equivalents, and if I'm being honest, that was based on the funding that was available whenever at the very beginning, and we then looked at that through a national resource allocation model. We divided that up across our health boards. So each health board, depending on the size, would have a number of facilitators. And those facilitators, some boards have maybe got, in terms of headcount, they might have double that because they might be part-time appointments, although the majority of them are whole-time. But they would be responsible for that board's supporting learning across both primary and secondary care. So they would work with the team leaders or the practitioner groups within primary care as well. But that's been quite challenging just in terms of the geography, in terms of the number. Our Highland areas, where we've got quite a number of remote and rural areas, quite a lot of the support that they give might well be virtual. So it might well be through teleconference, it might well be at the end of a phone call. So they would visit them, they would go out and they would look at work with the mentors, establish relationships, but then following some of that through, they might have weekly telephone calls or depending on what the need is at the time. So the way they operate is quite different across our country. And that's mainly because of geography. Okay. Yeah. Just moving on from that, I've been talking very much about the support at an undergraduate level and supporting mentors. But one of the things I've been asked to speak a wee bit about is about the transition from students to being registered practitioners. And we've talked about, over the past few days, I've been here talking about some of the graduate programmes. Going back to the mid-70s, 80s, it's been very clear that, to look at some of the research from the States, it talked about reality shock, people coming off programmes and then not being fit for practice, or the reality shock was so disturbing that people very often left once they'd completed their programme. We didn't have that issue in the UK because up until the kind of 90s we had an apprenticeship model. But once we moved more clearly into higher education, there was a perceived lack of preparation at the point of registration. And I say perceived because I think to some extent a lot of that was quite unrealistic in terms of the expectations that students would complete. They would come off their degree programme and into practice and be ready to hit the ground running, as we say. And there was never any sort of a benefit given to the fact of a need for a transition period. And that was we recognised that as a real gap. So we have to assume that people coming through our nursing programmes are fit for practice at the point of registration. And as they become employed, they are registered and accountable practitioners, whether a nurse, midwife or an allied health profession, once they're on the register. But we recognise the need for a transition period. So this is not an extension of their pre-registration programme. We expect the skills and the competence to be achieved. But what we've now called Flying Start NHS is a transition programme to help people move from being a student to being a registered practitioner, and to look at the application of their learning within the specific area that they're then going to be working in, and building their confidence over that first year of practice. Because one of the key things is about confidence to practice as a new registered practitioner, and making sure they've got the right kind of support. We were probably one of the only professionals groups that did expect people to be up and running in day one. It certainly wasn't expected within medicine or dentistry, law. Most people would have a sort of an intern year, but certainly not within nursing, and not within our allied health professions either. So we had a working group together with senior people from our NHS boards and our universities to look at, what would this need to look like, this transition? And we wanted it to be something that could be flexible so that it could address the needs of practitioners wherever they were working. we didn't want it to be profession specific. We wanted something that was much more generic than that. And we've come up with what we call Flying Start NHS. And it's about developing confident, capable health practitioners. And I don't underestimate the confidence element of it, because one of the key things is when new practitioners come in, how challenging it is when they're not confident to practice, and there's a safety issue there. Equally, there's a safety issue if they're overconfident and they think they do know it all. There's a big issue there. So the whole issue about confidence is much more complex. So we wanted to make sure that they are safe and confident and competent within the area that they're working in. So we designed this programme that's designed to be completed within the first year of practice. It's absolutely learner directed, providing a supportive, guiding learning environment. Most successful when it's undertaken with the support of a mentor. And I say most successful then, I would say that's almost essential. Any new graduate coming in should have the support of a named person, whether you call them a mentor, a support pair, support preceptor, whatever. They need support, a named support person in that area. We wanted something that was easily followed with downloadable learner guides and useful web links, and we wanted to make sure it was open to all healthcare settings for nurses, midwives and allied health professionals. We've developed this programme then that consists of 10 learning units, and you can see on the right hand side the 10 units are communication, clinical skills, teamwork, safe practice, research for practice, equality and diversity, policy, reflective practice, professional development and career pathways. There was lots of discussion about what needed to be in this programme, and at one point, everybody wanted everything in it. We need a bit more in terms of, particularly around about skills and things that you'd expect to have been completed within the undergraduate programme. So this looks quite simple, but it actually was quite complex to get here. We really did do quite a lot of work with the underpinning evidence for what people need in transition. We worked with practitioners, we worked with newly qualified graduates, we worked with key stakeholders, and that this was through a process of refinement we came up with these 10 learning units. The learning units each has its own aim and learning outcomes, and each has a subsection, and you can see in this drop-down menu, as an example, clinical skills has clinical skills development, assessment and planning, providing treatments, improving health, enabling others, reviewing care. And each of those subsections contain learning activities. So there's examples of what they could be doing and how they could be applying what they need to learn from here. And there would also be a link to relevant resources. And if I come down as far as the policy one is a good example, because during undergraduate programmes, quite often individuals are more concerned about the theoretical underpinning rather than some of the policy drivers. And while they might be aware of the policy, it becomes much more meaningful when you're actually working within a healthcare system and understanding the influence of policy. So we find that the policy one's a good example of one where they would then be interested in looking at what the links are, what they need to know, what's driven some of the things that are going on within their area. So the programme is structured around these, and it says at the bottom there, all activities are linked to the NHS KSF, and that stands for Knowledge and Skills Framework, and that's a national UK-wide knowledge and skills framework that we have that's linked into personal and professional development for all practitioners except doctors and dentists within the NHS in Scotland. And it's got various different elements like continuing professional development, communication, supporting, supervising others, equality and diversity. So this complements what's expected from the national function as well. We implemented this in 2007, and I have to again be quite honest, it was really pushed by our government in relation to trying to get a national consistent programme for newly qualified individuals for that transition. Every single health board had their own induction programme, and most of them, a lot of these were very, very good programmes, but again there was no consistency across the country, there was no consistency and therefore very limited transferability. So the amount of time if people were moving, having to undertake from scratch again new programmes. So we wanted something that was consistent and something that would be valued as recognising the need for that transition from registered practitioner from student to registered practitioner, and really legitimising that, because it absolutely is a legitimate support need. It wouldn't work, and it's very much not an e-learning package. And I think it's important to say that. It's not about, here's an e-learning module you can go and do. It is about a programme that people need to work through. And it absolutely requires the commitment of managers, and it requires the commitment of mentors. So that's why we see in this triangle, we need all of that in place. So we need support within our board areas to help to deliver it, and we need to make sure there's a commitment to managers to allow people to undertake this programme. The other thing in relation to evaluation, it's not a linear programme. People they're not expected to work through that unit by unit. They work through it depending on the context of their practice. So, for example, it might well be that they're dipping into the communication model at one point, team building at another point, depending on what's going on in their practice and the work that they're negotiating with their mentors. Just in terms of what we would see as our key successes, we've now got, I'm saying 25,000, and I would say that's probably sitting at 30,000 now, newly qualified nurses, midwives and HPs who've registered on the programme. It has given that clear message to both practitioners and managers that a period of support during transition is legitimate, necessary, and it's valued by the organisation. It does provide a consistent approach across Scotland so that it allows for recognition of that learning and transferability. It has clear links to the NHS staff development policy and process, and it is flexible to allow individuals in the context. So whether you're working in an acute area, whether you're working in primary care or a voluntary sector, it's flexible enough to accommodate that. The issue about recognition of learning, it's not an accredited programme, and I think that's also important, but if learners are wanting to go on and do some postgraduate study, they would be keeping their evidence of their learning within a portfolio that they can then use for recognition of prior learning with their universities. And we've had discussions with the universities. They've been involved in looking at how they would actually quantify that and how they could actually support that. From a practitioner's point of view, what they've told us is that it helps to manage expectations and legitimises the need for their transition. It provides context-specific application of their learning, so it allows them to think about their learning in the context of the area they're working. It gives up-to-date learning material, national policies and useful websites, so we make sure we keep it absolutely up-to-date in relation to what resources are required in there and what they might need access to, and we respond very closely to their feedback if there's any gaps in that. It draws on and builds on the learning and skills developed at registration, promoting confidence and capability over time. And it's that confidence and capability over time that's really important. As I say, it's not about an addition to the pre-reg programme. It is about, even if they're undergoing, and even if they're deciding to undergo post-registration, master's level programmes or beyond, they will still be expected to undertake Flying Start and complete Flying Start. But it's not all been that easy. Some of the challenges that we've experienced and continue to experience, I would say, we haven't got all the answers yet. We had significant variation across organisations about the implementation. Some organisations were absolutely delighted to have this model. Others were absolutely antagonistic towards it because they had their own induction model and didn't really want to see anything new or different. Albeit in developing the module, we did work with our practitioners, our stakeholders, to make sure we had all the key elements in here. The factors which influenced success was really the level of support and commitment at all levels. We absolutely needed our managers to be on board, and we needed to make sure there was a named mentor for the individuals newly qualified. I've mentioned before about the Practice Education Facilitators. They've played a critical role in making sure that people had access to Flying Start and helping us with any teething problems. I've put in protected learning time, and protected learning time is something that everybody wants to have, and it does require, but that's been there's a variance in relation to that across not only organisations but across professional groups and disciplines. And it's left up to the individual, so really that's where we need the managers' buy-in. But most of our managers do actually acknowledge the time it takes for people to complete Flying Start, and they do tend to work in a flexible way, whether that's a half a day a week or a day every fortnight, a day. It's different across different boards. Oops. Sorry, just the other issue, that was protected learning time. Access to computers at work was a bit of an issue, and formal recognition of completion. But those are the challenges. We're now embedding it. We're looking at, it's a web-based resource. We can email you the web link so that you can have a look at that if you wanted to. It's something that's right across Scotland. It's now been licensed to NHS in England, so we've got Flying Start Scotland, we've got Flying Start England. We have Queensland Health are now using it for their allied health professions. So there's Flying Start Queensland Health. So again, it's continuing to develop and to grow. It's very easily customised to various different areas and organisations. I'm not in any way selling this. I'm just talking to you about our experience to give you an idea of the thing that we've done in relation to transition. But actually, it's actually worked quite well for us, and we're quite pleased with it. We've still got a lot of work to do about completion figures and about embedding. I'm going to stop there because I'm realising I'm going to run out of time quite soon. But just in case there was any comments, any questions.
That actually looks like a really interesting program from my perspective with a recent graduate. We often have a graduate person down here at Beaconsfield, and our context is different to the context that a lot of the other graduates are in. So having it so that you can use it flexibly looks really good to me.
Yeah. Mm-hmm. It certainly works for us, and it's something, as I say, you can go in and you can have a look at it. You can see what you think yourself, and it's it's there. You can get full access from the web without being registered for it, but you can actually get a good feel for what's in it. But I guess the point I was wanting to make through the presentation is it's not about this specific programme, but it is about having some sort of national consistency for transition, so that we've got a shared understanding of what we're trying to achieve. And for me, that's been the biggest thing about this. Having national consistency and something that's recognisable allows us to have a shared language around it, and it allows us to think about that from a quality perspective. But the only other thing I would say, this is all part of, we can't just look at transition without looking at our post-registration career structures. We have also looked at beyond Flying Start. Then we have an effective practitioner programme that's now online or on the web. And then we have an advanced practice toolkit. So we've got a range of resources that can actually help people right across the spectrum of their careers. And I think for any of this workforce development issues, it's really important that we don't look at any one of these areas in isolation of the others. We really need to look at that continuum from our healthcare support workers right through to our advanced practitioners, thinking about what education is there for these people and what support's there for the delivery of that in practice. And the two things, I think, do need to go hand in hand.
Any other questions? Or
I hope that's been some help, or even just giving you a feel for something that's going on in a different country. What I was saying, it's just really about sharing some of the learning that we have, and hopefully just raises some questions in your own minds in terms of some of the discussions you might have within your own networks.
okay.
A big thank you from Georgetown.
Thank you.
Thank you very much.
Hobart.
Yeah.
Thank you from Launceston.
Thank you from Bernie.
Thank you.
Thanks from Raspberry.
And thank you all for participating and joining in our first multi-teleconference. Thanks very much. And thank you, Colette.
Thank you. No problem at all. No. Bye-bye.
Bye.